Welcome to our sonography lecture on abdominal vascular pathology, part 2 of 5. This lecture is going to focus on inferior vena cava pathology, looking at thrombosis, IVC filters, tumor invasion, and enlargement. When blood clots form in the body, they typically form in the veins due to conditions being just right that the red blood cells and other blood materials start to kind of get sticky and clot together. So blood clot in the IVC is actually kind of rare unless there is some precipitating factor to it. And that's typically because the blood flow in the IVC is much quicker and less likely to meet these conditions that we need for blood clots to form. So the conditions that we typically look for is known as Virchow's triad, and that includes blood stasis. So blood is not moving in the way that we would expect, especially if somebody is bedridden or not using their legs much. That blood is not being pumped back up to the heart as quickly as it would be in somebody who's very mobile. We also look for vessel wall injury, so that might be through surgery or through an abdominal mass eroding the wall of the vessel. And we're also looking for hypercoagulability. Hypercoagulability means that the blood is more likely to coagulate or more likely to thicken and clot off. And that can happen due to certain medications, certain cancers, or even a genetic disposition for hypercoagulability. Now, when there is thrombus in the IVC, we do typically see this along with other conditions. One of the big ones is going to be DVT in the legs. So DVT is a deep vein thrombosis, and that is a blood clot within the major veins of the legs. And as that clot forms in the legs, it can continue to grow upon itself following the venous channels up into the IVC. This is typically why when we perform venous ultrasounds on one leg, we're always looking at the top of the contralateral leg to see if there is any IVC involvement. If that clot is extended beyond the common femoral vein, we can see it in the external iliac vein. We are going to need to check the IVC to make sure that that clot has not propagated all the way through the IVC. Abdominal masses can put pressure on the IVC, causing the blood to flow a little bit slower. It can also erode through the vessel wall and extend mass into the IVC, which then kind of catches the blood and can cause clots to form along it. There are certain times that patients are going to need central lines placed. Central lines are little tubes that are usually inserted into the venous system. They bring medicine directly to the right atrium so the heart can disperse the medicine very quickly. And so the central lines are a foreign object within the blood vessel. It causes wall damage and it causes something for the blood to stick to. And then lastly, we might see some clot in the IVC due to Budd-Chiari syndrome. If you recall, Budd-Chiari syndrome is the clotting of the hepatic veins that can cause blockages in the liver, but that clot can propagate then into the IVC. When we think about how blood clots form and what they are doing, they are typically blocking the blood flow back to the heart. So it would make sense then that our patients are going to have symptoms that kind of emulate what it would feel like to just have a lot of extra blood sitting in your legs. So they're going to have heaviness in their legs. It'll be painful. There's usually some type of swelling, and they might notice some cramping in their legs as well. As that blood backs up, and depending on the extensiveness of the clot or what's causing the clot, there might be some abdominal pain or back pain that goes along with it. And depending on where the blockage is, it might actually cause some collection of blood into the testicles, and so men might present with some scrotal swelling as well. On ultrasound then, we are going to use color to evaluate how blood is flowing through the IVC. So when we use that color, we will see what we call a filling defect. There will be no blood flow where the clot is present. In grayscale images then, we can typically see a little bit older clot as echogenic material within the lumen, but we need to remember that acute clot is typically anechoic, and so we should be using our color whenever possible to fully evaluate the IVC. So here's an example of thrombosis within an IVC. This is very obvious. This is a large clot, most likely due to some sort of tumor invasion going along with it. So we can see that very bright echogenic material within the IVC. If we were to put color on then, we would typically see probably blood flow in this portion here coming underneath and then continuing on. So we would consider this a filling defect. Here's an example of that filling defect. So we can, again, very clearly see this clot. So remember, older clots are a little bit brighter, but if this was a new clot, we might not be able to see this. So when we put that color on, then we can see the flow in the IVC surrounding the clot. Here's another example of IVC thrombosis. We can see a kind of stringy echogenic material within the IVC. We also notice that this is a little bit more dilated. That clot is most likely holding the IVC open a little bit more, causing a little bit more pressure to make it a little bit bigger. When a patient has very extensive blood clot in their legs or within the IVC, we need to consider what their clot burden is. Is there a chance that that clot could break loose and travel to the lungs? When clot travels to the lungs, it is known as a pulmonary embolism. To mitigate the risk of a pulmonary embolism due to a blood clot in the lower extremities or in the IVC, there is an intervention that can be done, and that is an IVC filter. So the IVC filter is kind of this mesh-looking cloth thing that is inserted into the IVC, typically done by an interventional radiologist, and its job is to catch clots as they might break loose and travel towards the heart. So it is to keep blood clots from traveling to the lungs. IVC filters are also known as green-filled filters, and once they are placed, the patient is usually put on some sort of blood thinner to get rid of the blood clots, and eventually the IVC filter is then removed once the clot burden has been reduced. Here are some examples of what IVC filters might look like. They do typically all have these kind of claw, net type structures that extend into the lumen of the IVC to catch blood clots as they travel forward. And here's an example of a filter within the IVC. We can see the IVC here. We can see the echogenic lines representing those finger-like extensions from the filter. If this patient did have a lot of clot that broke loose, then we might actually be able to see some blood clot also on the filter. Here's another example of a filter. We can see the IVC here and then echogenic lines within the IVC. Now this might be difficult to differentiate from actual blood clot within the IVC, but you should always review your patient history and note if they've had a green-filled filter placed. Another pathology that involves the IVC is something called tumor invasion. We know that as cancers grow, they typically don't just push anatomy aside, they typically grow through them. So IVC tumor invasion is related to cancerous masses eroding the wall of the vessel and continuing to grow within. Once the cancerous tissue grows within the IVC, it can cause blockages or thrombosis within the IVC, and the patients will present with similar symptoms to IVC thrombosis. These are seen most commonly then with renal cancers, both renal cell carcinoma and in children, nephroblastomas, which are also known as Wilms tumors. Here's an example of a tumor growing within the IVC. We can see the liver tissue here, so we are at the level of the IVC here, and this whole IVC is just filled in with echogenic material. The heterogeneity of this, the extensiveness of this, and most likely a cancer history leads us to believe that this is most likely tumor invasion. Here is a cross-section of the IVC. This is most likely a tumor coming from the right kidney. This is tumor within the IVC that is most likely extended along the right renal vein and into the IVC. The last pathology we need to discuss is something called IVC enlargement. We don't typically measure the IVC as it is not a diagnostic criteria. We know that it can change sizes with respiration. However, after you do quite a few abdominal ultrasounds, you'll become comfortable with what a normal IVC looks like, and when they become dilated, it will catch your eye. So if you feel like the IVC is a little bit larger than you would expect, go ahead and measure it. If it exceeds 2.5 centimeters, it is considered dilated. Enlarged IVCs can also be seen with dilated hepatic veins, so that might also be prominent on your abdominal ultrasound. Typically what causes dilated IVC and dilated hepatic veins is backup of blood through those systems due to right-sided heart failure. And because it is closely associated with heart failure, the IVC is typically evaluated by echosonographers. And so this is an example from an echo. We have the right atrium where the IVC brings blood into. And so we have a picture of the right atrium here. And we have a very dilated IVC. In echo, they use M mode quite often to measure things. So we can see that from wall to wall here, this area is representing the IVC. Wall to wall is 3.3 centimeters. So that is considered an enlarged IVC. Here's an example of dilated hepatic veins going into a large IVC. This one measuring just over the 2.5 mark. And that concludes our IVC pathology. Up next, we will discuss renal vessel pathology.